Hello, everybody. My name is Giora Sharf. I am from the Flute of Light, the Leukemia and Lymphoma and MPN patient organization in Israel. And I'm very happy to present to you today a study, the clinical and economic implication of hydroxyurea intolerance in PV patients in routine clinical practice in Israel. This is a study that was done by, I think most of you know, Professor Martin Ellis, who was the head of the MPN hematologist working group in Israel, and by another doctor, Professor Tamar Tadmor, by two representatives of our patient organization. One of them is a PV patient, Moti Levy, who is sitting on our board of the patient organization, myself, and there are a few other people from the MHO, which I'll explain. The study was presented as a poster at ASH 2020, and I'm really happy to present it here today for all of you. So what do we know? We know about PV patients that they have impaired quality of life and high risk of thrombotic events. They have a risk of progressing to MF, to myelofibrosis, as well as to acute myeloid leukemia, to AML, and also naturally they have increased risk of death. The treatment for PV patients in Israel includes today aspirin and phlebotomies for low-risk patients, while for the high-risk patients, there is only additional therapy of chemotherapy called hydroxyurea or Hydrea. And there are no other approved treatments for PV patients beside those which I mentioned, including interferon, which is being used off-label and by compassionate use of companies, but it's not something that every patient is guaranteed to receive. We know that 25% of hydroxyurea treated patients will demonstrate resistance or develop intolerance to the drug, and they are at increased risk. And there is a lack of data regarding the clinical and economic implication of hydroxyurea resistance and intolerance in real life setting. Additional drugs which have been approved in the world in many countries, like for example ruxolitinib, are not approved in Israel for PV patients. It was submitted for the last 3 or 4 years, but our HTA committee has always rejected the approval of this drug for PV patients. So what were the objective of this study we did together, the hematologists and the patient organization? It was to determine the prevalence of Hydrea intolerance and resistance in PV patients in Israel, and also to determine what are the clinical, psychological, and economic implications of Hydrea resistance or intolerance in Israel. So how did we implement the study? It was a retrospective real-world evidence study where we use the database of Maccabi Health Services. It is one of the 4 health provider insurers in Israel. We have 4 of them. Maccabi is the second biggest one, and it includes more than 2.2 million members. How did we choose the PV or identify the PV patient? So actually everyone who was recorded with a PV diagnosis, or it was if he had a complete blood count indicative of PV, and there was a follow-up of purchase of hydroxyurea for at least 3 months between the years of 2000 and 2015. So the patients that were included in the study were divided to 3 subgroups. One of them was a group which was resistant to hydroxyurea, and that patient who were prescribed 2 milligrams of Hydrea with no adequate outcome. The second group was the intolerant patient to Hydrea, patient who stopped Hydrea and transferred to another line of therapy or to another treatment. And the third one was the patient who was stable on the treatment. So the results, the number of the patients that were actually in the study, there were 830 patients included in the study. About 40% of them, or actually 38.3%, were intolerant to Hydrea. Only 3 patients were resistant to Hydrea, and they were excluded from the study and further analysis because it's a too small number. And 509, over 60%, were stable on Hydrea, and that's patients who actually did not meet any of the criteria of resistance or intolerance. When we look at the patient characteristic at the inclusion to the study, we saw that about male were the numbers were equal between both arms, the intolerant and the stable. About 54% 0.7 from the intolerant patient were males, and 57 in the stable patient were males. The age was very similar, 65 to 66. And also, when we look at the lab values at the first hydroxyurea prescription, we saw that they were very similar between the two intolerant and stable in regards to hematocrit, hemoglobin, the white blood cells, and platelets. You see the numbers were very similar. And also the number of phlebotomies before hydroxyurea was similar, 41% in the intolerant to 36% in the stable patient. And now let's look at the results that actually what we are looking at. When we look at the patient who were intolerant versus the stable on Hydrea, we saw that in deaths, almost two-fold higher rate of deaths in the patient who were intolerant to Hydrea compared to the patient who was stable, 58% compared to 30%. Patient who had thrombotic events was calculated per rate of 100 patient year. 100 patient year is a statistical way to analyze and compare data between two arms. And we can see that in the patient who were intolerant, it was over threefold higher thrombotic events compared to the patient who was stable. What about progression to myelofibrosis? We see that it was fourfold higher, 28% compared to 5%. And the Maccabi, the HMO, have a way to calculate the cost of treatment for patients. And when they did the calculation of the treatment cost, we saw that it was 2.6 higher for intolerant patient compared to a stable patient. Here we show it on a Kaplan-Meier curve, and you can see the time on the left curve slide, the time to thrombosis and thrombotic event, and you can see the intolerant patient who in the blue compared to the stable patient in the red. You can see that much quicker and number the intolerant patient are getting to thrombotic event, and also time to MF, you can see the big difference. Remember, it was four times fold higher, the number of patients on the intolerant compared to the stable, and you can see it clearly on the curve. The red one represents the stable patient, the blue one, the intolerant patient. When we look at the psychological outcome, again, there was comparison between the two arms. We saw that actually, how did we measure it? Patient which had at least 2 visits to a psychologist or psychiatrist, or they had 2 field prescriptions for psychiatric medication. So you can see in the results at the end that any visit or medication, again measured by 100 patient here, you see that the number of is higher for intolerant patient compared to patient who is stable, 30.8 compared to 10. It's 0.5. That's 30% more psychological visits and medication for patients who are intolerant. The same when we looked at hospitalization. This time it was the number of hospitalization days was calculated per 1 patient year. And you can see very clearly the total hospital days. When you look at the intolerant arm, it was more than 5 hospital days per intolerant patient a year, 5.27, compared to only 1.93 hospital days per year for a stable patient. So the difference is quite clear. So in summary and conclusion, in our study, we saw that almost nearly 40% of patients developed intolerance to Hydrea. And Hydrea intolerant patients had increased rates of mortality, thrombosis, progression to MF, hospitalization, and higher emotional burden compared to the hydroxyurea stable patient. And the Hydrea intolerance was associated with increased healthcare expenditure. Intolerance to Hydrea in PV has serious clinical and economic implication and they indicate that there is a unmet need for improved treatment for those patients. Ruxolitinib for PV, as well as also ropeg interferon, were submitted this year again to our HTA, and this time both of them received high grade versus the previous years. by our HTA committee. Because of the virus of the pandemic, the decision which was supposed to be made by the end of December was postponed by 1 month, and we are looking forward every day now to receive the final decision in few days. So finger crossed for our PV patients that they will have an additional treatment available for them to help them and to meet the unmet need. And I think that the results of this study can influence the HTA authority to approve the needed drug for the patients. So thank you very much for your attention.